Today, we've got a very special guest on A Psych for Sore Minds. His name is Dr Elliot Carthy, and he is a frequent YouTuber and also a psychiatric doctor like myself. So Elliot, welcome.
Thank you very much. Nice to meet you, and I'm really pleased to be here. Yeah.
And you, it's a pleasure. My first question would be for people who are maybe medical students or junior doctors who might be considering psychiatry as a career. So would you recommend it and why?
Oh, absolutely. Absolutely. I mean, I think the choice of specialty is always a very personal thing. I often find anybody that justifies their specialty, the first thing they say is, I love the variety. And people say that no matter whether they're an ophthalmologist or a psychiatrist or whatever. There's lots of reasons that I love it, but probably the biggest things are from the scientific point of view. I think psychosis is fascinating from a scientific and neurobiological point of view. So, and I think the science keeps you interested as a doctor. I think it's important. I love the fact that you can work with kids all the way to old age. So you've got the full sort of spectrum. I think it's intertwined with a lot of politics and social stuff, so just life in general, that's really interesting. And as a career side of things, it offers a lot more flexibility than what I found when doing physician specialties, for example. And I think that's really important. And the nights end at some point as well. You don't have to do night shifts for the rest of your life. And for me, that was really important.
Yeah, I've not done a night shift for a very long time, so I can definitely relate to that.
I hate them with a passion. It's my least favourite thing.
So are your nights when I did nights, when I was a JHO and then as an SHO and a registrar, they were really variable. So some of the placements, you'd go there and you'd basically sleep for most of it and very rarely get called out. And on other nights, like liaison, you're just bombarded with case after case. What's it like for you?
Same thing here. If you Google me, it's no secret that I live in Oxford. And so a lot of the placements that I've done are in Oxford. That's not something that's difficult to figure out. It's going to be groundbreaking on this video. The Oxford night shifts are busy. So you end up doing, you kind of have half and half. So half of your night shifts are covering the inpatient wards. And we've got about 15 wards across 3 different sites because we cover the forensic stuff as well. And then the other sort of nights are the A&E liaison nights. And they're all really, really busy. But then I have colleagues that work in other areas, not in Oxford, just outside of it, and they have nice sleepy nights. So it is a bit chalk and cheese, I think, depending on where you go.
You mentioned earlier about talking to people with psychosis, and I completely agree. It can be really fascinating, can't it? It's people who are really floridly unwell, because in their head they're communicating to you in a normal manner, but what's coming out of their mouth can often just be very disjointed, thought disordered, just delusional. But it's like a little window into what they're trying to say.
I think for me, I find it really interesting to speak to somebody who sees the world completely differently to how I do. And I think the way that we think somebody with psychosis sounds odd and bizarre, they must think that we sound completely odd and bizarre as well. Those things become at odds. And I think it's the power of the mind that I think is really, really fascinating. How we can almost treat that and make that, and it's sort of plastic in a way. I think that's really interesting. And I think you do have those little windows. I had a consultant once say to me, as a psychotherapist, the most common symptoms of psychosis aren't hallucinations and delusions, they're denial and rationalization. And actually it's about normalizing these things to try and cope. I also think the content of people's thoughts and voices is quite interesting because they're so dependent on the person and the environment they've grown up in and quite cultural as well. I think it says a lot about the person. And I also like the fact that we still don't really understand why it happens and how it works. There's this huge sense of unknown that is quite, as somebody that's quite academic as well and interested in research, that there's a lot that needs to be done, there's a lot to work towards. So there's lots of different avenues for what's a very devastating illness that I think is quite interesting.
I've always found when I come across people who are very paranoid and psychotic and are very evasive and guarded, it takes a certain sort of skill to try and tease out information and symptoms from them. And I've seen people do it really badly. I've seen nurses and doctors who are just too direct. There's no kind of empathy or warmth. They're just obviously there to try and get a symptom rather than, it's almost like a little game of slipping in your questions into conversation and letting it come out. And I think, I enjoy teasing it out of people and doing it well.
I think the way that I find is most helpful, again, there's all these little tidbits that I've picked up from working with different consultants over the years. In my F2 job that I did, it was a learning disability job, and that's still the field that I think is I think is most interesting within psychiatry, is what I want to do as well. And there's this term that's thrown around a lot called challenging behaviour, which is they're doing something that I don't like and I don't really understand and I want them to stop. And that's what's over the years and still today leads to a lot of sort of over sedating of these things. And actually it was what he said to me was, you need to understand the emotion that's driving the behaviour. Every behaviour is driven by an emotion. If you tap into the emotion and you actually spend a bit of time understanding it, you'll understand the behaviour and you'll stand a chance of being able to change it. And I think everybody that I meet that's got psychosis, particularly in the context of schizophrenia and I would say in depression for sure as well, fear is a lot of it. Fear is the emotion that underpins it. And actually, if you can try and reassure somebody they're in a safe environment and that you're there to try and help alleviate suffering, then I actually think that goes a long way to being given that little window to help explore what the symptoms are they're having, what the experiences are and how they're seeing the world, and then try and use that for a diagnostic point of view, but also just to understand how they see the world, because that's what we're trying to do.
And sometimes it's quite hard to put patients at ease, especially in inpatient environments. So I work on forensic wards, and as you would expect with mentally disordered offenders and people with histories of violence, some wards are not safe a lot of the time. So that's an extra kind of layer of battle that you've got of trying to get patients who are psychotic and paranoid to come out of their shell, when actually sometimes other patients on the ward are a bit scary.
And that's the thing, is you're taking people that are scared and distressed and maybe don't quite know what to do with that fear and distress, and you're putting them in an enclosed environment with other people that are scared and frightened and don't know what to do with their distress, or maybe only know how to go into the fight mode because they can't flight, which is what the usual response is to fear. And that can be really, really difficult, because then you end up having to do the more paternalistic side of psychiatry, which is, you know, when you have to think about at the extreme end, restraint and meds and all these types of things, which is never a happy thing when you are in disagreement with patients over these things, and can fracture sometimes that therapeutic relationship that then makes it hard to recover from.
Okay. So you've talked about the pros of psychiatry. What, if any, do you think are the cons of going into a career in psychiatry?
I think demand is going up. Demand for mental health care and secondary care is going up, and we're not being supplied with more resources to meet it. And I think some specialties are affected by that more than others. I think general adult, it's really difficult. CAMS, it's really, really difficult. I wonder, I've seen inpatient forensic stuff, and what I've seen maybe is slightly less affected, but in terms of the community side of things and facilitating, you know, discharge and integration back into the community, it gets affected. I want to do learning disabilities for higher training, and I think that's quite a small specialty with a small cohort, but again, it's intricately linked with the social care system, which has been just the brunt of so many cuts. And I think that for me, I find myself feeling helpless a lot of the time. So, for example, if I have somebody seeing them in a liaison shift, for example, in A&E, and they're taking an overdose, or they're actually really depressed, and the biggest factor that's perpetuating their depression is they're homeless, I can't change it. And I feel really there's no antidepressant that I can give that's going to counteract the harms that homelessness has. And it makes me feel really, really helpless. And I think that's something that I find really difficult. And I think we face that a lot more in psych than other specialties. Maybe A&E and GP do as well. But I think that we're sort of in that group where that's the biggest thing that we face.
Something that I think that's similar to what you're talking about is that psychiatry, and I'd argue especially forensic psychiatry, the job satisfaction is very subtle. It's not like you're a GP or a surgeon where you see a patient, you treat them, they get better. They're clearly, obviously better very quickly in front of you, and then they're grateful and they leave. It's not like that at all in the patients that I see. They don't want to be there. They're detained against their will. They're sometimes medicated against their will. Often don't have insights. They don't understand or agree with what you're trying to do. And I mean, there is some job satisfaction, but it's a slow burner, and it's about keeping people safe in the long term for many years rather than getting them better quickly in front of you.
Completely agree. You need to be interested in chronic disease. And I think, particularly when you're at med school, I think med school is very good at teaching you a lot of acute stuff. Because actually, I think in your first year, that is more important. You need to be able to feel comfortable with a sick patient that's acutely deteriorating and know what to do without completely freezing. But actually 99% of medicine is chronic disease. That's stuff that we can't cure, that we just have to manage, that will probably progress at some rate, and we're trying to reduce the impact it has and the speed of progression. And that's the same with diabetes, heart failure, COPD, chronic kidney disease. Psych has a bit of a rep as if it's more so in psych than other specialties, which I don't completely agree with, but you need to be really driven by long-term goals and long-term satisfaction, I think, to do psychiatry. And also, yeah, don't expect Christmas cards and nice bottles of wine and presents to patients at Christmas. Yeah. That will not happen. Go into orthopedics or ophthalmology or something like that for that, but you won't get it in psych.
You have to expect a degree of customer dissatisfaction, basically.
I think so. You're gonna have to prepare for the fact that some people may never see the world as you see it.
Yeah, they
never will. And you can try and, again, alleviate some of the suffering and try and help them manage symptoms a little bit more. But that's the nature of our illnesses, is people see the world differently, and we can change it to some degree, but we can't always align it with us, and nor should we. But yeah. And that means we don't always see eye to eye, and that causes problems.
I think for me, another con of doing psychiatry, and I do love my job, and I'm glad that I did it, and I wouldn't, if I could go back, I would still choose the same specialty, I think. But something that I'm very aware of that makes me feel a bit uncomfortable is I feel like I've been de-skilled in terms of my acute medicine. I've not taken a blood test for, probably over 15 years now. I've not examined a chest for probably just as long. It's probably less for you because you've done your training more recently. But I would panic, I think, if I was in an emergency situation compared to when I was a junior doctor. Do you ever feel like any twangs of regret for not being able to use all this information that you're kind of overloaded with in medical school and as a junior doctor?
No, because I still feel like I use it quite a lot. I feel that some of the skills that I learned in my first year, the practical stuff when someone's crashing in resus, I don't use that so much, but I think indirectly what it does is you see the extreme end of things, and then you stop panicking over those things a little bit, because you do it over and over again, and you see people that are really sick, so you get to spot what's really sick and what's not. So I think one of the things that you find tricky out of hours when you're the doctor that's on call as an SHO sometimes is when someone gets physically unwell and you think, actually, can I manage this with the next to no resources that I've got in a psych hospital? Or do I need to think about transferring this person out? And there's a huge amount of risk and cost involved with that. And actually you're taking someone that's distressed, investing in an environment that maybe isn't good for their mental health. So there's risks either way. And I think the physical health experience you get acutely, sometimes, for me, I can use that by going, no, I can sit on this. I don't have to send this person to A&E at 3 o'clock in the morning. Actually, we can manage this a little bit here, and we can bash brain cells with the rest of the team in 3 or 4 hours' time, because I know that we've got that time, and that we don't need to rush them out in the middle of the night, and that actually risks doing harm. And I think from the chronic disease side as well, so many of our patients have lots of other chronic physical comorbidities, some of which are just coincidental, that lots of people are at risk for, some of which are with the same societal risk factors of poverty and things like that influence mental illness, and some of it is directly caused by us and the drugs that we give them, particularly diabetes and cardiometabolic disease. And so many of them smoke, so there's COPD and all of these things that come in there. And I think you have to be somewhat competent at managing those things. Yeah. I think we have a duty as psychiatrists to stay somewhat competent with managing these things, because they're so linked with our patients. So I think we use that. So I find I use more than I anticipated I would.
Okay, fair enough. And in terms of your overall training, what are your thoughts about how junior psychiatrists are trained? Do you think we get enough exposure? Do we get enough placements? Do we get moved on too quickly or not? What do you think?
So with core training, I like the fact that it's 6-month placements. So it's 3 years of 6-month placements. And I think the thing that I get frustrated with is the privatization of things like addiction medicine, for example. So there's next to no addiction jobs at all. So and it's such a big problem that you deal with, either as a comorbidity or something, as a single pathology. And I really, really wish that we had more of that. And that for me is a big problem. So that's, I would say, but I think 6 months is usually long enough. Usually long enough to get experience that you need to treat the medicine in that field. I think one of the things that I found, and it was interesting, it was doing a forensic job that helped me realise this, and I was doing my long case of psychotherapy when I was doing my forensic job. I find for a lot of our patients, particularly those in maybe that have been through lots of different trauma and stuff in early life, it's really difficult for them to trust. And when you've got this rotating cast of doctors every 6 months, they go, well, why am I going to bother exposing myself and letting somebody in when they're only going to leave me in 6 months' time?
Yeah.
And I think that's another thing that means that time limit sometimes means you don't really get a window into the mind of that person, because they don't want to let you in, and that's all a product of their past experience. And I think in forensic settings I'm seeing that more, but I think that may be representative of a higher degree of early life trauma that's sort of led to those paths.
I think you're right. I think it is more rife in forensic patients because almost all of them have such a longer history of trauma compared to the average psychiatric patient. And you have to ask them about their index offence at some point, because that's the whole reason they're there. That's the basis of at least part of their rehabilitation. So you're right. A new face comes along in 6 months, befriends them, ask them the same really personal questions over and over again. You form a bond, then they disappear. And even the senior doctors, you know, I think now more than ever, people are chopping and changing, coming out of jobs, leaving because they're unhappy. It's quite there's a lot of flux, and it's quite chaotic in a lot of places I've worked.
I think I found that in those settings, a lot of the patients that I've met have had so much inconsistency in their early life, and that's all they've known, and they are just desperate for consistency and predictability. The only thing that they could rely on is the fact that someone's going to leave, because they always leave me. And I think that being there for 6 months and having that time limit, you can plan for your endings a lot better, but you are going to leave. And that can make it really difficult to build the therapeutic relationship, and that limits the learning opportunities, I think.
Yep, absolutely. I agree. I think something that affected me, or something that I noticed when I was doing my training for both the 6-month placements as a SHO and then the year-long placements as a registrar, is the quality of the consultant. So I've worked for some very excellent consultants and some pretty poor consultants. And you can learn next to nothing in 6 months if your consultant does the absolute minimum, doesn't give you any responsibility, doesn't go out of their way to give you any training, or you can learn a lot. And I think part of some of the way to do it, one of the best ways to do it is to throw you in at the deep end. So I've worked with one particular consultant that sticks out in my mind, whereas when I was a junior registrar, he just made me do all the ward rounds, made me do everything really under his supervision for a set of patients. And it is really frightening at first, but then you get used to it very quickly, and then you start thinking like a consultant instead of thinking like just another person writing notes in the corner of the room.
Yeah, absolutely. And I find the other thing that is helpful, especially as a junior, just be present where the patients are. Be present. Don't hide in the office when you're a junior if you can help it. You know, for me, I if I wasn't actually having to sit and do paperwork in the office, I would just be out on the ward. I would, even if it's just having a cup of tea in the corner with one of the nurses while you can kind of see what's going on, because when people let their guard down and maybe they don't realise that you're watching them in a very false and quite intimidating environment that ward rounds can be, again, you can spot things a little bit. You can see somebody that's talking to something on the wall, or you know, feeling agitated here. You can see who gets on the ward and who doesn't, and why these dynamics might be there. And you get an idea of what's normal for somebody or not, and therefore you can see whether somebody's getting worse or whether they're progressing. And also, if you're there, the more you're present, the more they will learn to trust you as well. And I as much as I think, we really, as a SHO, we really want to be like our consultants, where we get to be in the office and do paperwork, and we don't have to be caught up on the ward doing all this stuff and everybody bugging us all the time. I think be present. I think that's the best way to learn as an SHO.
And also as a consultant as well. I think there are consultants that, again, just go on the ward maybe once a week, or sometimes even once a fortnight in forensic wards, just to interview their patients for the briefest possible period of time. And there are other consultants that are extremely present. And I think you're right. If the patients let their guard down and open up, just by seeing that you're around and that you care, I guess. My next topic is, I know that you're going through your exams. Have you finished them all now?
Just finished. So I passed the CASC exam. I sat it in September. It was the first of the remote sittings that they've done to adopt for COVID. Right. So yeah,
congratulations. I always, when I went through all my MRCpsych exams and the CASC, I personally felt that they were not a very effective way of actually testing our knowledge. So the written exams were so detailed, like you go into absolute minutiae. Rhesus monkeys I had to study about. I don't know if the syllabus has changed since then, but that was just one of the areas. And it's absolute minutiae, to the point that you learn a lot, but you forget a lot as well. And it's hard to prioritize what you actually need to remember. Yeah. And I thought the CASC was, well, the stations are so short and that it's like a little game show. You have to, instead of actually honing your clinical skills to be effective, you have to hone them to be really, really quick. So those are my thoughts. I was just wondering what you thought about the whole system, about how examined.
I agree. I agree with the sentiment completely. I think the difficult thing is how, from designing an exam point of view, I imagine, like putting myself in the shoes of the Royal College, how can you create something that's valid and reliable and reproducible and standardised, so that you can compare trainees against each other to see who's competent and who's not? And the only way you can really do that in something like Psych is to have actors that can give you a standardized way of portraying a certain illness. It's the same reason that in when people are doing MRCP, if they're a physician, when you're doing PACEs, you don't have anything acute. You've just got people with chronic stable disease where you can reliably pick up signs, and they can compare who was able to pick up this list of 5 different clinical signs that this person has. So I think it would be unrealistic to ever think that any of these exams are going to be really representative of real life. And I think when you prep for them, you have to prep for them as a game. A bit like you prep for a driving test, you've got to prep for them as a game. Otherwise, you're only doing yourself a disservice. Yeah. I think part A we did, and that part A was super obscure. So that was the written one where you do all the old neurobiology and developmental stuff and psychology and stuff. That was super obscure, and I've already forgotten most of that because it's not something I use in clinical practice at all. Yeah. That's gone the same way as the Krebs cycle and all that stuff that I've never used since then. Part B was a little bit more relevant because it was a lot more, there was like lots about clinical guidelines, which were quite useful. And then there was, I think, a third of it was statistics, which I probably use a tiny minuscule amount of that, even in the research that I do. And I'm more academic than my colleagues. And so I've not used most of that. So I think most of my colleagues just ditch all of it at the end of that. My CASC experience was okay. All of the stations that we had were very, very fair on common things. But it is about time management. We had 7-minute stations, which is, in real life, you're sitting and speaking to a patient usually for half an hour, 40 minutes often, especially if you do something on liaison, maybe even longer. And you have to try and succinctly do that in 7 minutes while also not appearing rushed, even though you are rushing.
I think that was my main problem with it, was that the stations were too short and they weren't really reflective of somebody that was good at taking a history of listing symptoms. It was just whether you were fast.
Yeah.
So in terms of where you are at your training, I remember when I was a registrar and there was a fear of whether there'll be enough jobs around, especially in your geographical area. And there were always horror stories of registrars who just couldn't get a consultant job and had to end up moving like miles to a different city or another part of the country. I was wondering if that kind of fear still exists around your cohort.
I think the bottleneck at the moment is when you're applying at registrar level. So, for example, I want to do learning disabilities, and that's so undersubscribed because not many people even know the specialty exists, let alone want to do it. Yeah. So there's quite a lot of registrar posts and consultant posts, so that's not so bad. But actually, we've only got in our local area, I think like 2 general adult SPR posts every single year. And when we've got like 20 core trainees or something like that, there's a complete and utter bottleneck. So I think if you get on an SPR post locally, you'll probably be okay to get a consultant job. But the bottleneck is getting an SPR job, at least in our area at the moment. Okay. I think it's quite similar. I think, anaesthetics have a similar problem. They have lots of, core anaesthetic trainees and then just a minuscule number of SPR jobs that causes a real bottleneck.
But am I right in thinking that there's not quite as much pressure because you can do like fixed term jobs, or you can do like standalone jobs until a registrar post becomes open? And you can do that before your consultant job, but it doesn't look good. And the longer you do that, the less employable you look in the eyes.
Oh, really? Because the people start asking questions about why it took you so long to
exactly
or something. Right, okay. But yeah, and I think there are quite a lot of sort of staff grade or specialty doctor grade jobs around that are not training, but you can make sure you can still pay the mortgage.
So just to change subjects a little bit, I'm going to put you on the spot a little bit here, but can you think of like a case or an experience that you've had that you would want to tell our viewers about that really stuck out in your mind? So like an unusual patient or just an interaction or something that you learned from a particular case?
Oh, I suppose One of the things that I've learned in the last few months, I'm listening to Barack Obama's audiobook at the moment when I'm doing stuff in the lab, and he talks about the audacity of hope, in his words. And again, it was something I learned when I did my long case, is how hope is so incredibly powerful, and hope can be, I think, for a lot of people, motivating, but at the same time, hope can be extremely provocative. And I've seen a few cases now where if you give somebody this little bit of a goal, if you do this well, then we can think about doing this, and that gives maybe a little bit of motivation, but then they go, well, I'm going to screw it up at some point. I know I'm going to screw it up, just like I've screwed everything up. And then eventually they hit the screw it button and they just go, well, let's throw it out the window, because then I don't have anything to lose anymore. Yeah. And I can think of, particularly my long case, where a lot of people have real difficulties managing hope, particularly when they've been constantly let down in the past. I think that actually underpins a lot of different disorders that we see.
So what's the solution?
Address it and be open about it. I think point out the elephant in the room and say, how do you feel about this at the moment? How much of this is motivating you and how much of this is terrifying you?
Yeah.
And just actually put it out there and let people be allowed to feel motivated and scared at the same time. You're allowed to feel two different emotions at the same time, two different, almost contradicting emotions. You are allowed to feel them at the same time. And I think if you validate that, then you actually go to some steps to being able to manage all the emotions that come with it.
Yeah, that's a good answer.
That's what's worked for me in the past.
I think you've hit on an interesting point there, which is that we don't really often get the patient's insights and feedbacks into how their therapy is going. Like, I know it's like a tick box on your CPA form, but it's not. It's almost like we've got a plan for them, and they slot into our plan, and we say, "This is what you need to do. This is what's best for you." And I think you have to step back sometimes and appreciate that there's no point making a perfect plan if the patient's not on board. At some point, it's gonna go off the rails somehow, either because the treatment's not effective, or the patient's not engaging, or, as you say, they press that sort of self-destruct button, whether it's taking drugs or not taking their medications or whatever it is. So I think that's an important point that gets overlooked, and it's not something we're really trained to do. It's just you kind of pick it up over time.
No, and I ask myself every time I try and make crisis plans and things like that for people that are in distress, and maybe we're going to try and manage it in the community where we can. I always try and ask myself, how much of this is me wanting to say, I've told this person that they can do these things, or they can call this person, or they can call this person, and how much of this is us actually having a discussion about whether somebody would do that or not, and what are the factors that are stopping somebody from doing that. So you're taking it from a tick box exercise to something realistic and implementable for that person.
Yeah, and unfortunately, I in the psychiatry that I see, there's a lot of tick boxing. There's a lot of, it has to be documented that I told them that they call this number if they're in crisis, rather than, as you say, would they call this number if they're in crisis?
Yeah, well, you're writing for lawyers, aren't you? And you're documenting for lawyers a lot of the time, but you are. Unfortunately, there's a lot of cases that come back to this and about the length of documentation. Yeah, and but that's pervasive across medicine, and probably across a lot of the public sector, I imagine, as well. I imagine the police and schools and teachers and all this stuff have similar issues as well, just as the way that society has moved on.
Yeah, and I think it's getting worse. I think people are more litigious as time goes by. So I've got a question for you about anti-psychiatry, the movement and the people that are involved in it. So I know you're quite active on social media. So my first question is, do you get a lot of kickback from people telling you that you don't know what you're talking about, or that psychiatry is wrong? What kind of comments do you get, and how do you deal with it?
So I don't get that much. But also I actually try not to engage with that stuff, because I think Twitter's a weird place. A lot of people on Twitter at the moment are just out for a fight, just for the sake of it. And it's just this constant state of projection of anger and worry and anxiety that just gets sort of passed the parcel around a lot of the time. And I think when people are doing that, they're not in a place to necessarily reason or have a rational conversation in 280 characters. So what's the point in just sort of fanning the flames, really, with these things? And I see other doctors get caught up in that. I've got a few comments if I've posted anything, for example, that's mentioned anything like ECT, for example, that usually leads to a barrage of things. And there's a little bit when it comes to medications and pharmacology as well. People saying that we're over-drugging people and that we're all biological and we've completely rejected Freud and all of these types of things, which is just nonsense. Yeah. And I try and judge the tone of the tweets as to whether I actually bother responding to it, whether it's going to lead to a dialogue or not. I don't need to be the last person that answers to say I was right.
Yeah. I think, so I'm quite new to all of this. My YouTube channel's only been going on for a few months. And I do get a few kind of quite challenging comments, and it is quite a struggle because I want to tell, not because I need to be right or I need to have the last word, but I think that there is some validity in what they're saying in some cases. But the problem is they're making quite aggressive and blanket assumptions. So to take a specific example, like you said, over-medicating patients, that does happen, and that is a valid area to look at. But that's the minority of patients, and sometimes you have to medicate patients quite heavily because their mental illnesses are just so strong that if you don't, then they're just tortured by voices and symptoms. But you can't really, as you say, you can't get that nuance in 280 characters. So you either have to have a really long protracted battle, or you have to ignore it, which is a shame because I think there's a conversation to be had there.
Yeah, particularly I think clozapine is the one that seems to have triggered most of it whenever I've made a comment about clozapine, because I mean it does have loads of different side effects, really serious side effects, and ones that can be life-threatening for people. But you don't. But what a lot of people don't really get is how mentally unwell people are when it comes to clozapine, and what limited other options that we've got. Yeah. And actually, it can be completely life-changing for some people as well. But it is risky, but we acknowledge the risks. We're not trying to hide away from the fact that it causes you to become morbidly obese and diabetic and just dribble to your heart's content. So I think that's there. But I think a lot of the anti-psychiatry stuff is one of the reasons that I wanted to start the YouTube channel a bit, because actually I think when you go onto places like YouTube, there is a bit of an anti-psychiatry voice, but maybe not so much anti-psychiatry, it's just pseudoscience and an anecdote that's masquerading as fact. And there's very little out there from an evidence-based point of view on mental health and psychiatry. And I think you need to be... I think psychiatry has a bit of a tendency, especially because of its history, to want to live in the shadows a little bit more, because you're worried about amplifying the voice, the anti-psychiatry voice, or worried about the controversy of the fact that sometimes at risky situations you have to use things like restraint and meds against someone's will, and you don't want to get backlash and controversy for that, so you'd rather say nothing. But all you do is leave these misinformed views unopposed, and you avoid this dialogue and you avoid this conversation. And I think that means, given the number of people that are going to come into contact with a psychiatrist at some point in their life, that leads to people being terrified. That's one of the things that contributes to why you meet people in A&E and they go, "Are you going to section me?" straight away just for having a conversation. They think that we can do that, or still think that we use ECT for social control on the wards, and it's all stuff from a perception from the 60s and 70s that hasn't moved on because we haven't told people how it's moved on.
I couldn't agree more, absolutely. And especially when you think about the huge proportion of people that have mental health issues, actually there's very little credible information about what psychiatry is and what it involves. Completely agree. So that leads me quite comfortably onto my next question, which is about your YouTube channel. So you've already alluded to why you started it. Can you tell us a little bit about your journey, how long you've been going, pitfalls, what you found difficult, what's gone well?
So to some degree, I probably posted like my first video maybe like 18 months ago or something like that. One of my favourite bits of my job is teaching. I love teaching. I've always loved teaching from when I was a teenager, teaching various different things all the way up through undergrad and med school and things like that. And I kind of was thinking about new challenges, about how to try and expand my teaching repertoire. And I applied for, there's a group called AUTP, the Association for University Teachers of Psychiatrists, I think. Maybe I got that wrong. And I applied for a very small little scholarship with them to try and start something up with this and do my first couple of videos. And it takes a little while to get comfy. I'm still trying to get comfy with it. But the idea of it was to try and create something that's evidence-based about mental health that people can use as an accurate scientific resource rather than too much about sort of anecdote and opinion. Then as time goes on, you realise actually it can be quite difficult to be consistent like you need to be with YouTube, particularly when you're doing the number of on-calls, and that's probably been my biggest downfall. with sort of, that's limited the growth of things. And then you've got to learn how to feed the YouTube algorithm, which I'm still getting my head around a little bit. But the idea is to provide something scientific and evidence-based for people to understand what a psychiatrist is and what we do and why we do it.
Okay. That's a very thorough answer. Thank you. Is there anything that you've learned from making your YouTube channel that surprised you?
How time consuming it can be to write the scripts and to do the editing and things like that. I mean, I'm quite good because I like teaching. I'm quite a good storyteller. So I can, and that, because I think that's what teaching is at its heart. It needs to have a beginning, a middle, and end. You need to know your audience, and you need to build this story up in a logical way and have some goals to get towards without overloading things. And I think YouTube is exactly the same. Problem is, I don't have a creative design eye for these things. So that's one of the things I know really holds me back and that I struggle with, and that's really difficult. I also think that people's opinions on YouTube, particularly doctors on YouTube, can be quite polarized. There's some people that think it's really interesting and really good, other people that think it's an exercise in narcissism. I mean, we're all a bit narcissistic with doctors, aren't we? Let's be honest. So yeah, I think managing people's opinion is the other thing, or how much I care about people's opinion, I suppose, is the other thing.
Yeah, because you really.
If you feel something similar.
Yeah. So I can definitely relate to the how long it takes, how much time it consumes. So I naively thought that I'd probably spend like one afternoon a week just writing a video there on the spot and then recording it, and that'll be done. But it's so much longer than that. As in terms of feedback, it's been a bit mixed. I mean, we're still growing. We're still at the early stages. And yeah, I'd agree. It's been quite polarizing. So you get some people who are quite engaged and quite interested in what I'm saying, and then you get a lot of people, as we were saying before, who are clearly anti-psychiatry. And I don't have a problem with people being anti-psychiatry. And in fact, I revel at the opportunity to talk to people and to learn from them and to express different views in a healthy way. But it's never a healthy way. It's always like, they just go for your jugular, basically.
I've not had too much anti-psychiatry stuff in the comments, and I get people messaging saying that they're coming from psychology backgrounds or social backgrounds, or they're at various different stages, which is really nice to attract more than just sort of junior doctors and medical students and things like that. I think the polarizing opinions for me have been from friends and colleagues. So not posting, but friends and colleagues and their opinion of why you do it. But then people have strong opinions about whether you should be on Twitter, about whether you should be on Instagram, about media medics. There's tribalism in medicine everywhere as well, where everybody's trying to one up each other. It's not always a very friendly environment, and I think it translates over to that sometimes. You just have to think about whose opinion is worth something, whether there's substance to it or not. So
have you had colleagues that have discouraged you from making YouTube videos?
Not actively discouraged, but people that look at you a little bit like, well, just what you try to carve out some massive media career, you big narcissist, and just a bit judgy on those things, but they have those same opinions towards people that have 40,000 people followers or something on Instagram as well, and they're not engaged in any social media, and they just have a bee in their bonnet about social media. That's fine. Okay. That's absolutely fine. I respect people's opinion to disagree or to not like it. That's fine. What I'm listening out for when people are commenting on it is, have people got an opinion about the content and the message that I'm giving, and whether there's an issue with that? That's the stuff that I really need to listen to. If somebody goes, actually, I don't like the way that you said that, it gives the wrong impression, that's something that's really, really important for me to change, because that goes against the core of why I started the channel. Okay.
I think I can understand how some people are a bit skeptical about social media, especially if they're a bit older and they didn't grow up with it. I think I was right on the cusp. I didn't really grow up with it. And I was skeptical, and I still am. But I also think that this is the way that young people absorb material. So either as psychiatrists, as doctors, as professionals, we ignore it, or we engage with it.
Yep.
And if you ignore it, then like you said before, there's going to be misinformation or a lack of information. There's going to be people who are non-professional who are putting out anecdotes and opinions as fact. So it's not up to us to choose which platform we use. We have to use the platform that everybody else uses.
Yeah. Keep up or step aside, really. Just because you're burying your head in the sand and you're avoiding it doesn't mean the whole social media wheel stops and that other people stop accessing it. People are accessing it. Most med students now as well, from an educational point of view, no one reads a textbook anymore. No one reads a textbook. Mostly people are going straight to YouTube when they're trying to understand something. You know, you do it when I was an F2 doing my A&E job and things like that. You know, I'd do the same thing sometimes. If I hadn't done something in a little while, I'd quickly Google it. You're not searching for a textbook anymore. There's no point writing them. You've got to keep up. And you can create something really valuable. Even doing MRCPsych, you realise there's no real educational resources out there for our level, which is, you know, maybe something else that could be changed in the future. But
speaking of the future, slightly surreal question here. Have you got any thoughts of what psychiatry will look like in the future, say 20, 30 years from now? How do you think it'll be different?
I hope more joined up with general medicine than it is at the moment. I think I've always been a little bit torn, for example, with, you know, the idea of having separate psych hospitals to where the general hospitals are. I think a lot of the psych hospitals are in some really beautiful buildings, on some really lovely green landscapes, which is really therapeutic for people. But I wonder, when people are having so many complex health needs, whether that's really the right thing. Because what I see in the future is we're going to be better still at treating these chronic comorbidities. People are going to be living a little bit longer to accumulate even more chronic comorbidities, and our patients are going to get more complex from that point of view medically, not just from a psychiatry point of view, but from a gen med point of view as well. And I think we need to make sure that we're integrating a lot more with that. And I think that this physical separation that we've got between psych and general hospitals, I think hinders that. Yeah. So I think patients are going to get more complex. I wonder really about whether we're going to make much more headway with drug discovery. Yeah. And how our treatment is going to evolve or not.
Because we've really done so little in so many decades, haven't we?
Yeah, I think, and at the core of it, I think our understanding of the pathophysiology of mental disorders hasn't really evolved over the last 30, 40 years. We're still stuck on the idea of serotonin and dopamine for everything. You know, our treatments, the targets of them have basically remained the same. We've just refined them to make them a little bit more safer, to try and maybe change the side effect profile so that you can be helping with people manage their illness in the community, you know, and helped with the move away from all the asylums and stuff. And I just can't even see at the moment any particular buzz that's going to lead to a new development of a new therapy. I know there's lots of hot discussion about autoimmune encephalitis and things like that, but I think that might be for a small subset, but I don't necessarily think for the majority of people. And I think the other thing that I worry about is more cuts to the social sector, and I worry about the widening gulf in inequality, because I think that underpins a lot of mental disorders. And I think that that's where people's risk factors, in a lot of people's risk factors for mental disorders, it starts at -9 months. Yeah. And we don't intervene at that early point, because, you know, when a social worker should be knocking on the door and helping people, we don't have enough. They do the best they can, and I worry that gulf is going to increase, and that's going to lead to the burden of mental illness getting worse. Yep,
absolutely, I agree. Something that's occurred to me, especially during the coronavirus lockdown, is that we've been asked to do a lot more remote assessments and video assessments, and I have very mixed feelings about that, because I think ultimately the quality of the assessments will lessen, but you can see a lot more people in a shorter space of time, and especially when you have community teams that are just overloaded. For me personally, I tend to find the criminal assessments I do are not particularly effective over a video call, because you have to be in the room to really get symptomatology.
Feel it.
Yeah, absolutely. Yeah, you feel it. But the civil cases are generally a bit simpler. So I think you can do some basic assessments. So I've kind of wondered where that's going to go, because I think there's a good chance that people are just going to try and encourage more remote assessments in the future. And I'm not sure if that's a good thing or not.
No, and I think you're right, and you need to always be thinking about what's the purpose of the assessment and what's the best way to do that assessment. And I think when you've got people that are, you know, that maybe they come to A&E a few times already that year with similar issues, and you've got a decent idea of what their background is, and it might be 2 hours before I get to see them in person, or I can do a remote one right now, where you don't quite need to feel it as much to be able to create a decent plan, and it's only a very transient relationship and a short-term relationship you're going to have, rather than trying to build a long-term one. I think it really has a place. But I think when you are there to try and pick up the real subtleties around a diagnosis, real subtleties, that very slight flicker of the eyes, that very slight fidgetiness that somebody might have, the restlessness in the legs that you can't see below the camera, I think we do risk really missing stuff, particularly for new assessments.
And also the transference of how that patient makes you feel, which can be an important part of the diagnosis.
Completely. I think it's one of the most diagnostically useful tools that we have. You know, when you feel something, that feeling has come from somewhere and is informing something. So absolutely, I completely agree.
So my final question to you, Elliot, forgive me, it's a bit personal, but I noticed on one of your recent videos, you talked about your sexuality. So my question is, it's in two parts really. First of all, did you get any feedback from that? And if so, what was it? And secondly, how do you feel that the psychiatry as a specialty welcomes people from different sexualities?
Conflicted. So I've had great feedback on that video, and I've never really had hostility at all in psychiatry from a personal point of view. In terms of where Psych sits with it, I think there's some stuff about it, but in terms of LGBT plus stuff that we do really well and stuff that we're doing really, really badly. I think that the stuff that I think we've got quite a lot of people from LGBT populations training in psychiatry as well, and I think that is a really big thing in terms of representation, and I think that's really important. I think that as psychiatrists, we do have to be educated about lots of different cultures and backgrounds, because that informs a lot of symptoms that people present, how they perceive illness and all of these things. And that's LGBT, but obviously that goes beyond that as well. One of the things I touched on in the video is feeling conflicted, because in your head you think homosexuality being a mental disorder, that's from decades ago, right? That's from back in the 50s and the 60s. It's really not. You know, it really wasn't officially really taken out of the ICD until the early 90s, whatever the edition was then. And then actually going through it, even in the current edition, finding this F60 something, these weird codes at the back that most psychiatrists go, well, we don't really deal with that. But they're there about, sort of ego dystonic, sexual orientation and all of these types of things, trying to still label that someone's distressed with coming to terms of who they are in terms of either their gender or their sexual identity, and the distress and the worry that comes with that the cause of that is pathological in itself. And I really don't agree with that at all. And I think that by continuing to have codes like that in there, I think that sets a bit of a statement and is holding on to our bad past. And I don't, for no benefit, I cannot see any benefit in having it there whatsoever. There's lots of different social and cultural factors that can lead to somebody feeling distressed. And I think the example I gave in the video was thinking that someone that's got depression because they've been made redundant, and that's the big precipitant, we don't label them with employment deficit syndrome. We don't label the cause as pathological. We talk about their current mental state and why that's there, and in a narrative can think about the trigger. Yet we always, in our diagnostic terms, are still including anything to do with sexual orientation or gender. We're holding on to this idea that it's something that might need treatment. And I think we really do ourselves a disservice, because I think in practice we've moved on, but written like that, I think that puts us in a bad light. Yeah, very good point. Very good point. Something else that you touched on was the fact that psychiatry does have quite a dark past. Everything from lobotomies to institutions to ECT done without anaesthetic, and I think that it's something that we should be open about and talk about rather than hide, because it's a part of our movement, really. I think it's one of the reasons that we do hide now, and there isn't so much openness about what psychiatry is, because we're worried about opening up these cans of worms, and maybe it's just sort of institutional avoidant behaviour. But I think if you look at lots of different specialties, if you look at gen med and surgery, they'll have their own sort of barbaric practices by today's standards that happened 50 years ago. But I think we're right up there with things like the lobotomy. We're right up there with, insulin coma therapy and ECT for just lots of different things to do with social control rather than mental disorders, and things like that. And I think we do have to be open about it. And I think we can be open about it and say, look at what we've learned and look at how we've moved on. And this is not how we practice now. You don't need to be scared of us because you think that this is what we still do. Yeah. People know more about lobotomy than what we do now. Yeah, and for people to understand what we do now, we have to, as you say, be open about it and honest about what's gone on in the past. I agree. Elliot, it's been an absolute pleasure to have you on. No, it's been lovely, thank you. Before we finish, can you tell our viewers about your YouTube channel and what to expect from it, please? Yes, so my channel is self-titled because I couldn't think of a witty name like you've got for yours, so I just went the narcissistic route and named it after me. So it's titled Dr Elliot Carthy, and I do a variety of different videos, educational videos to do with mental health. So sometimes it's me chatting about some of my experiences, sometimes it's talking about specific mental disorders, sometimes it's doing some stuff about pharmacology and neuroscience, and sometimes it's watching stuff in the media and actually explaining some mental illnesses that are depicted in the media and whether these are accurate or not, and how we do it in real life.
Okay, that sounds excellent. So everybody should go and check that out. Elliot, thank you so much for coming on.
Well, thank you.
All the best. Goodbye.
Thanks a lot. Bye.